So first thing I want people to understand about dementia is a terminal disease. Uh, People think of dementia as having a fairly extended life expectancy, and some people hear about people surviving for many, many years. But in fact, it is a terminal disease. The median survival is 3 to 6 years. Some people say 4 to 8 years, but there is very limited life expectancy, certainly with dementia, particularly when we talk about advanced dementia. The prognosis for advanced dementia, which is about 1.5 years median, is comparable to someone with severe congestive heart failure or metastatic breast cancer. And it's my opinion, the opinion of most experts in dementia care, but also the opinions of most individuals, lay people, and other members of the healthcare team, that palliative care is the most appropriate care for advanced dementia. And most of you on the call may know what palliative care is. It's been mentioned quite a bit. It was spelled successfully by many of you. Palliative care is the care focus is a team approach to care with doctors, nurses, social workers, therapists, working with physicians as well to enhance the quality of life of the patient as well as their family. Palliative care is also hospice care, but hospice care is sort of defined really by the Medicare hospice benefit, which limits hospice care to the final 6 months of life when the doctor, the hospice physician, as well as the attending physician agree the prognosis of this individual, regardless of dementia or diagnosis of metastatic cancer or heart disease, that their prognosis is likely less than 6 months. But the care they receive is palliative care, which is focused again on managing symptoms, whether those symptoms be physical or psychological, and spiritual care for these patients. What we're talking about today is the group of patients with advanced dementia, dementia having really categories breaking down generally into 3 categories: mild, moderate, and then advanced dementia. Advanced dementia are people, individuals whose dementia has progressed to the point they have profound memory deficits, total functional dependence, means they need assistance with everything: bathing, dressing, toileting. They're usually incontinent, no knowledge of recent or past events, little or no verbal communication, limited ability to ambulate, or no ability to ambulate. So that's the definition that Dr. Susan Mitchell, who I think is the leading geriatrician in the country, honestly, because of her experience and her published works, is how she defines advanced dementia. Now, people with advanced dementia are prone to having medical complications. They can have pneumonia through aspiration. Scott mentioned about swallowing difficulties, which is very, very common, feeding difficulties, weight loss. They can have infections, particularly pneumonia, urinary tract infections, infections of decubitus ulcers. And they have very, very commonly neuropsychiatric issues. Probably 90% plus of patients with advanced dementia, will have what we call behavioral and psychological symptoms of dementia. It's very important that patients and actually I should say families understand, because when we talk about advanced dementia, we're talking about people that no longer have the capacity to participate in decision making. So it's very, very important that families, specifically the decision makers in the family, maker or makers, understand their prognosis. And the median survival is 18 months. 25% of people with advanced dementia will die within 6 months. And if they have an episode of pneumonia or a febrile episode, or have what would be defined as an eating problem, swallowing difficulties, losing weight, these would worsen their prognosis, as you can see. So if they have an episode of pneumonia, for example, they those patients would likely have close to a 50% chance of dying in the next 6 months. That's important because the 6 month, because you can't automatically say somebody with advanced dementia qualifies for hospice, because they have to have a likely prognosis of 6 months or less. So this information is quite useful in determining eligibility for hospice. Now, the reason families or decision makers need to understand prognosis is because it alters decision making significantly. In this study done again by Dr. Mitchell, when family members understood that the prognosis was less than 6 months, the chances that they would send their loved one into the ER or the hospital for aggressive care was only 27%. But if they believed the prognosis was greater than 6 months, the chances they would send them in to be hospitalized was 73%, a dramatic difference. So the family's understanding of prognosis is very important, and unfortunately, it's often not communicated at all or very poorly by the physicians, because many physicians that are caring for dementia patients are not well trained in this part of care and are uncomfortable prognosticating. Many distressing symptoms in people that have advanced dementia. They can have shortness of breath, that's dyspnea, pain, pressure ulcers, agitation, aspiration are all very common. All reasons that palliative care can be very beneficial, because we do focus on physical symptom management to a significant degree. The neuropsychiatric symptoms of dementia, Scott mentioned these, and Dr. Peterson mentioned these in his video: agitation, aggression, delusions, hallucinations, wandering, insomnia, sexually inappropriate behavior. This is not an all-inclusive list, but these are very, very common issues that need to be dealt with in patients that are suffering from advanced dementia. And the benefits of non-pharmacologic treatment need to be highlighted. They were earlier in Scott's presentation, which was excellent. We need to focus on bathing is often a point of agitation for patients, and there's studies that actually show with person-centered bathing, I won't go into a long description of that, it can be very soothing for patients. Aromatherapy can be helpful. Exercise, music therapy, I would like to underline everything that was said about music therapy. I think it can be of enormous benefit to patients at all levels of dementia. When these fail, or when they're not available, and unfortunately, they're many times are not available. One of the things that we're seeing in Minnesota, and really I think very much across the country, is there's really a shortage of trained providers, caregivers in facilities, in both assisted living and skilled nursing facilities. And consequently, we're seeing a lack of provision of person-centered care apart from medications. And that's very sad, but it's a reality. And in fact, there was a New York Times piece that was published several months back that indicated that many people with advanced dementia are being categorized as having schizophrenia now, so that they can have the use of antipsychotic medication, primarily just to sedate them, and so that they can be more easily cared for, because that's the only tool in the toolbox that facilities have now, and they don't have adequate training of caregivers. And this should be illegal, but it really needs to be more closely regulated. But it's a tremendous issue right now, the overuse of antipsychotic and psychoactive medications in patients with dementia. Scott mentioned this is very important. I want to highlight this. Agitation is a common problem in patients with advanced dementia, and one of the issues behind this is pain, untreated pain. In this study, which was done in Europe, they took 352 dementia patients at 8 different nursing homes, and they managed patients with agitation with pain medication. And sometimes that was simply Tylenol, and if that wasn't effective, they would use low-dose opioid therapy, things like hydrocodone or oxycodone, or even low-dose morphine. And they found that there was a significant reduction of agitation and aggression in these patients, no change in their cognition or ADL capability. So control when you don't know what's causing agitation, and I do this very commonly in our hospice patients. If they're agitated and we don't know why, we give a trial of pain-specific medication. It's often very effective. Persistent pain is very common in nursing home patients. I'm going to skim through a couple of these slides. This presentation was originally an hour. It's pared down to 30 minutes, so I'm going to go through some of these slides rather quickly. Untreated pain leads to a poor quality of life with loss of ADL function, poor sleep, poor mobility, depression, and anxiety. There's pain, there's modalities other than simply using medication for pain, and some of those are listed here, and they can be very, very helpful. I think Scott mentioned also polypharmacy. Unfortunately, we see an overuse of medications in this population. It's very common when someone's admitted to hospice for them to be on 10, 12, 14 medications, which is very unfortunate. Polypharmacy can actually be a factor in leading to nursing home patients. It can cause impaired mobility, increased morbidity and mortality, more frequent hospitalizations. There have been studies that have shown that when you use more than 5 or 10 medication, patients have a lot of complications from these medications. There's what we call prescribing cascade that's common, where a medication is used to treat anxiety. It's not effective. There's side effects. Another medication is used to treat the side effects of the original medication without the original medication being discontinued. And this can go on, leading commonly in many of these patients to them being on 5 or 6 or 7 psychoactive medications. In this study, they stopped medications in a group of elderly patients, average age 82, and about 3 drugs were stopped per patient. The failure rate of dropping medications that they did not think were indicated was only 10%. Only 10% of the drugs had to be restarted. And the patients did very, very well. They had no significant adverse events. Their overall improvement as judged by family was 88%. And that's improvement in terms of quality of life as assessed by family, mood function, and cognitive capacity. So polypharmacy is an important issue to address in the elderly. I want to get into the area of advanced care planning, which is really the center point of this presentation, which I want you to think about and really ask any questions that you have about this. This is really critical for these patients to make sure that they get the kind of care and treatment that they would have chosen for themselves had they been able. The principles of bioethics have to be underlined here. The patient side of ethical decision-making is autonomy. Every patient has a right to do what they want with their body when it comes to medical treatment. No one is allowed to touch your body unless you give them permission to. And when I say that, I'm talking about in a medical sense or any physical sense. And that's based on U.S. Supreme Court decisions. Now, when someone has mental capacity, they can make their own decisions about medical issues. But when they lose mental capacity, as people do with development of dementia, particularly in moderate and certainly in advanced stages, we use substituted judgment, which means hopefully we can use an advanced directive that they've outlined what their wishes were about medical treatment, or they've appointed a surrogate decision maker, somebody to serve as their healthcare agent. Hopefully they've done both. So the healthcare agent can collaborate with the medical team for decision making. Many times people have done none of the above. They have not done an advanced directive. They haven't named a healthcare agent or healthcare power of attorney. And then we resort to the legal principle of best interest. We say to ourselves, what would a reasonable person want in this situation? From the professional side, beneficence and non-maleficence are the two cardinal principles of bioethics, which means we must always act to benefit patients, and we must always act to avoid harming patients. In skilled nursing facilities, and I'll tack on assisted living facilities, we want to individualize advanced care planning by using what's called the PULSE, Provider Orders for Life-Sustaining Treatment, which is something that's very available in North Dakota and in most states in the country. It's a national program, and people can list what their goals are, whether they be towards life prolongation with full aggressive care or focus on comfort care. But there always should be a focus on palliation, enhancing quality of life and comfort for patients, regardless of age, really, and regardless of diagnosis. Now, this is very important to understand in terms of trying to extrapolate and try and identify what the wishes are of somebody that has moderate or advanced dementia. This study was done 30 years ago, but I think the information is still very relevant. And Dr. Emanuel looked at a large group of patients that were coming into an internal medicine clinic, average age 60 years old. And they were asked, if you had dementia, what would you not want done to you? And if you had dementia when you were terminally ill, and I guess we would call that advanced dementia, what would you not want done? And CPR, ventilator, IV fluids, artificial nutrition and hydration, major surgery, minor surgery. As you can see, 3/4 of people, even if they had a diagnosis of dementia at all, would not want any of those types of intervention. And again, these were people with full mental capacity at age 60. And if they had a terminal diagnosis of dementia, and I'm going to say that's synonymous with advanced dementia, 80–85% would want none of these interventions. Now, this is even more compelling in terms of surrogate decision making here. When you look at this study by Dr. Volandis, when he actually showed videos to people, similar group of patients, this time age 58, 120 relatively healthy people coming into an outpatient clinic, but with full mental capacity. And he gave them the narrative description of dementia that I showed earlier from Dr. Mitchell, comparable to Dr. Mitchell's description, and said, would you want comfort care if you had advanced dementia, limited care, life-prolonging care, which means CPR, ICU care, and so forth. And 50% chose comfort care, 20% life-prolonging care. He showed them a video then, just about a 4-minute video of a woman with advanced dementia interacting with her 2 adult daughters. And after they'd seen the 4-minute video, 90%, 89% chose comfort care. No one wanted life-prolonging care. So the best way for people to make decisions is if they surrogates is to really understand what this illness is by seeing it. So how do you get to the right decisions for people with advanced dementia? You have a loved one, as I did with advanced dementia. How do you get to a reflective advanced directive? Or I should say an advanced care plan would probably be a better term right here. And I think the most important things are the words that are used. And I wanted to give you all an example of the words that I've used over the years that I have found to be both reassuring, comforting, and really enable people to make, I think, the right decisions. And what are the right decisions? The right decisions, as was mentioned in an earlier video, are the decisions that the patient would have made for themselves. So, and that's how I try and frame it. So I say to the adult daughter, what would your mother have wanted if she had, in her good mind of 5 or 10 years ago, had seen herself in this condition with advanced dementia? Would she have wanted medical treatment to prolong her life? Or do you think she would have chosen care focused on comfort? This brings me to a story of episode a number of years ago when I was admitting a patient to a skilled nursing facility with advanced dementia, a gentleman, and his wife was his decision maker, his wife of many years. And I saw that he was full code. And I thought, well, that's kind of curious because that's not the choice that most families make for their loved ones with advanced dementia. And I said to her, I said, ma'am, your husband has chosen to have full aggressive treatments done. And I'm wondering if your husband was able to make his own decision about the kind of treatment he wanted in the condition that he's in right now, knowing that he has limited life expectancy with advanced dementia. Do you think he would have wanted medical treatments used to prolong his life? And she started to tear up and choke up and said to me, if my husband was able to see himself in this condition, and if he had a gun, he would end it. And he went from being full code simply by asking that question, would he have wanted medical treatment to prolong his life, to being comfort care only based on that decision. She unfortunately had not been asked that before by anyone, or someone had asked the question to you, should we shock him and bring him back, which is a ridiculous question. We'll get to that in a minute. So it's very important how we frame these questions so we can enable the right decisions, the decisions the patient would have made for themselves. And then I go on to say, if you're not sure, let me provide some information, some advice that may help. Think about your mother's attitude towards life, about the value that she saw in her independence. Think about her views of medical treatment. Finally, think about what your mother would want given her advanced dementia and limited life expectancy, would she have wanted to have her care focused on comfort or life prolongation? And then we use the pulse. This is a section of the Minnesota Pulse. And, you're going to be using, most of the people I presume are from North Dakota on the phone, and North Dakota Pulse form is available through the Honoring Choices North Dakota website. And it's an excellent form with a lot of explanatory information about advanced care planning. And please review it and use the North Dakota Pulse so that people can be enabled and empowered to have their decisions acted on by emergency medical providers. Because the Pulse form will allow them to pick what types of care they want. Whether it's care focused on comfort, limited treatment, which usually means hospitalization with IV fluids or IV antibiotics, but stopping before intensive care or intubation, or finally full aggressive treatment or life-sustaining treatment, which would include CPR, ICU care, major surgery, and the like. It's important to consider hospitalizations in this group of patients because they're commonly hospitalized. In this study, again, done by Dr. Mitchell, where would I be without Dr. Mitchell's work? The advanced dementia patients had an average of 1.6 hospital transfers in the last 90 days of life. So nearly 2 hospitalizations or 2 transfers to the ER for the average advanced dementia patient, which is very unfortunate. Dr. Mitchell reviewed all these hospitalizations and found that 75% of them were either unnecessary or inconsistent with the preferences of these patients. So that's very burdensome to transfer these patients to the hospital, particularly when it's unnecessary or not consistent with their wishes and values. So I go on to say to the children or the spouse or whoever the decision maker might be, hospitalization can be very upsetting for a patient with advanced dementia. She could not understand the tests or treatment. These can often be uncomfortable and painful. Plus, a hospital is an unfamiliar environment. It is often best to focus on comfort and surroundings that are familiar by staff that know her. And we talk about CPR, which is often really a moot point, because if people want to focus on comfort care for their loved one based on their knowledge of their wishes and values, and they want a comfort care and a natural death, then CPR is contraindicated. It's not an appropriate treatment. Even if they're considering CPR, I say to them, I strongly discourage CPR in the nursing home. It rarely provides any benefit. The very few, maybe 1 out of 50 that survive return in an even more deteriorated condition. And these statistics that I'm giving you in this slide are based on the medical literature, on reviews on this very subject. There's also sections in the Minnesota Pulse on antibiotics. The North Dakota Pulse does not contain an antibiotic section, which is not a problem because it's not really, honestly, it's been shown not to be very helpful, frankly. Both North Dakota and Minnesota have a section on nutrition, artificial nutrition, and hydration, so people can express their wishes on that. Let's talk just for the last few minutes on artificial nutrition, hydration. Scott talked about this. It's a very important issue because this is essentially universal in patients with advanced dementia, that they develop nutrition issues because of swallowing problems that develop, lack of interest in food, and choking episodes that occur because of swallowing problems. And tube feedings gets raised as an issue. Fortunately, the good Lord is compassionate, and he didn't mean us all to die with increased pain because we can't eat or drink. And there's decreased thirst in the elderly that's been documented and studied. Terminally ill patients often develop what we call the anorexia of dying, have decreased hunger and often no hunger at all, and decreased thirst as well. But tube feedings are brought up frequently on patients with advanced dementia. It's ironic because the feeding tube, also often called the PEG or percutaneous endoscopic gastrostomy, a tube going directly into the stomach to feed patients, was developed by pediatricians to feed preemies in neonatal intensive care units who couldn't swallow adequately. But by 2005, 300,000 were being put in a year, and most of them in patients over 65, 3/4. And at the time that this study was done, and this was in the mid-2000s, 34% of patients with advanced dementia had feeding tubes, which I was astounded by. It was much higher in certain states, much lower in other states. Minnesota was fortunately quite low. But a lot of people look at feeding tubes as really part of basic care. And no different from hand feeding, but the Supreme Court doesn't look at it that way based on the Nancy Cruzan case of 30 years ago, a woman with a vegetative state whose family, after 7 years of no improvement in a vegetative state, requested the feeding tube be discontinued so that she could be allowed to die, which they felt was consistent with her wishes. And these were two very loving parents. The Supreme Court decided that the liberty guaranteed by due process must protect an individual's deeply personal decision to reject medical treatment, including artificial delivery of food and water. And Justice Sandra Day O'Connor articulated it this way: artificial feeding cannot readily be distinguished from other forms of medical treatment. Unfortunately, doctors are misinformed about tube feeding. I think this has improved somewhat in recent years. This study was done quite a few years ago, but I think there is still way too many patients with advanced dementia being put on tubes. This was a study of family physicians, about 300 of them. They felt that tube feedings would decrease pneumonia, improve nutrition, heal pressure ulcers, improve survival. None of those are true based on medical studies, but that was the impression of these family physicians. So you can see why they would advocate for tube feeding. Tube feeding, this is opinion of this physician: a demented patient with eating difficulty, a conscientious program of hand feeding is the appropriate treatment. If the patient continues to decline, tube feeding might be considered. However, all who make or participate in the decision should be clearly informed that the best evidence suggests it will not help. So I say to family members, the decision makers, swallowing difficulties and weight loss are symptoms of advanced dementia. Comfort can be provided by altering the diet, providing food that are easier to swallow, or hand feeding. When death is near, the appetite is lost, comfort can be provided by keeping the mouth moist. And finally, I say to patients who I think are candidates for hospice, possibly, since your mother would want her care focused on comfort, I recommend that we consider a hospice evaluation. She's entitled to it. It's a Medicare benefit. It would provide an additional level of care here at her home. Nurses, social workers, chaplains, therapists, and doctors, all of whom would have the goal of maximizing your mother's comfort and dignity, would be involved in her care. So let me make one final point before I've got to close this up in 1 minute. Feeding is such an important issue. I want to tell you what I put in my own advanced directive, because this is so important. I've seen many advanced dementia patients kept alive for months, if not years, by hand feeding. For me, and this is a personal decision for anyone, I would not find that a dignified way to live, to be kept alive with hand feeding in a state of advanced dementia. So I put in my own advanced directive that I do not want any hand feeding. If I can't feed myself, then no hand feeding. There's also, I've been asked by patients and families about stopping hand feeding on patients, because they say mom or dad, if they knew the condition they were in, would want to have their feeding stopped because they would not want to be alive. If they were able, they would stop eating and drinking. They're not making a voluntary decision to eat and drink. Can't we stop it? That's a very hard question. And I think I'll hold off on answering that until maybe we get into the panel discussion.